I'm a former Boate, your MC. We thank God so much for ushering us into the float. We are here to continue the program. Please let's invite Madam Doreen Tanya to give us the first prayer.
Please shall pray. Our Father in heaven, we thank you this morning for the gift of life. Thank you for the strength to be gathered here. We commit our gathering here this morning into your hands. We are asking for success in whatever that we be doing. That at the end, we shall have every cause to say thank you once more. In Jesus' name we pray with thanksgiving. Amen.
Amen. Madam Doreen, thank you so much. Please, I welcome you all to today's program. We are in for thyroid disease awareness. And it's always a privilege to create awareness, as some of us and a lot of people are suffering from thyroid diseases without knowing. And even when you prompt them, they will tell you, even the thyroid gland they don't have. No program is complete without a chairman. Please let's introduce Madam Mary Lincoln to come and introduce the chairman for the program. Madam Mary.
Thank you very much, Madam MC. Good morning to you all, ladies and gentlemen. We would want to take the opportunity to thank you for your patience and welcome from the float. We are here this morning to create awareness on thyroid disease, and it's time that we know that it's part of NCD diseases so that patients with thyroid disease are not left out. So in this symposium, we are privileged to have in our midst a very fine gentleman who is a staff of this hospital. He's a medical doctor, not just any medical doctor, but a specialist, a physician, family physician specialist. He's also the head of department for the outpatients and the triage unit. He's in no other person than our Dr. Gabriel Atipo. Please welcome him.
Thank you, Mary, for your fine introduction. Good morning to you all.
Good morning.
Yes, and I'm privileged to be called upon to chair this program. When I saw the flyers going about on the social media platform a couple of days ago, I thought it was so remote from me. Surgeons in April, more kind of say prominence. Now, maybe if I'm home brain. Yeah, but come to look at it this morning and looking at the theme for the celebration, I don't know how many of us feel like the theme is jumping at them, screaming at them. It's a thyroid disease, NCDs. Also, for me, I'm seeing an exclamation mark there. And that brings to fore the biases that we all have when it comes to dealing in our subspecialty areas. The physicians see hypertension, diabetes, and those ones as NCDs. The surgeons see their cancers and all that. Then very little cross-fertilization happens. So for me, it really stood out for me. Thyroid disease is screaming that yes, we are also NCDs. So whatever portion of the cake that goes to NCDs, let us have our bit. Yes. Thyroid disease is seen by both physicians and surgeons, as we all know. And it is this collaboration that we should continue embarking on. It's good that Thyroid Foundation Ghana, in their short existence, 6 years from what I see from the flyers, have seen Eastern region as a prime destination to come. I guess all this while you've just been in Accra, UGMC, that beautiful facility. Okay, but we are privileged this morning that they have found us befitting of their presence. They are not only here to build capacity, but I understand that they also offer some support to clients in that where they have operated, they have managed to beat down the prices of thyroid surgeries. So we are happy to have them here. Let's be patient and listen from a renowned surgeon and build capacity. He's giving us a lecture on thyroid diseases. Let's learn, and thereafter, let's collaborate and help our patients who have NCDs. On that note, I want to say I'm privileged and I accept to be the chair for the function. Thank you.
Thank you so much, our fine chairman, for accepting to be our chairman. I shall invite Madam Mary to introduce the dignitaries in our midst. Auntie Mary.
We are very much privileged that at such a wonderful occasion, the management of this hospital has done that as ITAW, they've taken time off their busy schedule to be here with us to grace the occasion and make sure that things goes on successfully. So with no particular order, I would first want to introduce Madam Mary Oponsakwetia, who is the head of administration for this very important hospital. We would also want to introduce Dr. Pham Mrs. Betta Abeka. She is the head of pharmacy for the hospital. We will also introduce Dr. Esibe, a pediatrician in this facility. We would also take the opportunity to introduce Mr. Daniel Insia Ado, Deputy Head of Finance. Yes. So he's here to ensure that most of our finances issues are sorted out. The QA manager is here in the person of Madam Gloria Kofakwashi. The head of department, the block matron for adult OPD is also in our midst. Let's introduce Madam Gloria. We also have the block matron for maternity of Sengaini, Madam Irene Lebois. You are welcome. Then we also have the block matron for pediatric department, Ma Faustina, is also here on the list. Myself, I'm also here. All right, the last but not the least, somebody will come and introduce him. So I'll leave the mic here. Thank you very much.
Thank you so much, my able partner, Auntie Mary. Please, let's keep it up. We thank God so much for how far He has brought us. Please, it is my singular honor to introduce my madam, the founder and president of Thyroid Ghana Foundation, Madam Dr. Nana Adwa Konedu Chai.
Thank you very much. Good afternoon. It's a privilege to be here at Kokoridia. They say Kokoridia flowers, so I'm standing up so that I can see all the flowers in this room. Today we have more men than females. Am I sure I'm not? It looks like we are letting the men beat us today. So please let's send messages to those who are waiting so that they come in. Alright. So the Thyroid Ghana Foundation has been in existence for the past 6 years, and we've been working with hospitals in Accra mainly because I'm based in Accra. And that doesn't mean we don't see patients beyond Accra. So we see patients all over the world. We have some patients in Cotonou, Egypt, and all over. They call us when they see our programs and then they reach out. And so some we give psychological advice, we give counseling and all that. So our work cuts across, as our chairperson said, that we rely on each other to get a holistic health. So we want to be be here at Koforidua this year. This year we decided that we are not doing our program in Accra. Come May what, we are going outside Accra. And through, I give the credit to the former medical director, currently my CEO at the University of Ghana Medical Center, Dr. Kwame Enimbuama, who I discussed this issue with him. He was like, oh, Koforidua, go to Koforidua. And Dr. Akoto Ampia is there, Dr. Amponsa is there. They would help you, they will be there, they'll be willing to welcome you. And indeed, when we came here, they opened their arms and welcomed us. So I'd like to say a big thank you to the medical director, to the clinical director, and to all of you who have supported us with the planning team, chaired by Madam Akofa. I salute you. I salute you and your team for putting this together and for helping us coordinate this from Accra, because we are not based here. Without you, this wouldn't happen. So we give all the credit to you and we say God bless you so much. So we gathered here for two purposes, for the lecture and also to launch the collaboration with the Eastern Regional Hospital for our project that we've been doing with a lot of hospitals. We're doing this with Kolebu Teaching Hospital. We're doing it currently with the University of Ghana. We've done it with the University of Ghana for long, since 2021. Project subsidized thyroid surgeries. So when we say project subsidized thyroid surgery, what we mean is other hospitals that they don't accept the regular health insurance. When we have patients going there and they are not able to afford, we raise funds, the foundation help raise funds to help pay their bill. So hospitals that they also they accept the health insurance, we still top up, because the patients are supposed to top up, make the difference after the health insurance is applied. There's still always a difference to be paid, which is about 40% to 60%. So that one too, the foundation comes into the needy. We are able to establish if a patient is needy or not, because as human as we are, some people, even when they have the money, once they can get a subsidized, why not? So we work with social workers who help us in that regard to establish if a person really needs that support. And we know that now that we are here, we'll get that support from the quality and then the social work team to be able to really give it to the needy, so that it's not like all one cup fits all. So follow us on our social media handles, Thyroid Ghana Foundation. We are on Facebook, we are on TikTok, we are on YouTube, we are on Instagram, we are on all the social handles. So please follow us up, and we are hoping to get a bigger collaboration with Penn State University. We started the negotiation and then the talk with them, and we don't want them to do that collaboration in Accra, because a lot of the foreign organizations come and they get stuck in Accra. We want to bring it either in Koforidua or Cape Coast or anywhere else apart from Accra. So we are hoping that today, marking the start of this collaboration, we'll be able to continue and then make it bigger and better. So without much ado, I would like to say a big thank you to some of our people who have supported us to make today's program a success. I would like to say a big thank you to the Thyroid International Federation, which the Thyroid Ghana Foundation is a member. I'd like to say a big thank you to Ghana Gas. Ghana Gas has been our supporter for some time now. We would like to say a big thank you to the Daily Guide Network, Guide Radio, the Daily Guide papers. They publish our articles for us. So if you have any article on thyroid disease, you can let us have it. We'll get Daily Guide to publish it for you for free, because we have a collaboration with them. We want to say a big thank you to Hill Pharmacy. We want to say a big thank you to the Rotary Club of Eastern Region, which they call the Rotary Club of New Jabbing. If my P was here, he would find me. So we'd like to say a big thank you to them. They also help us with the collaboration. A big thank you to Afra Media Consult for all our design. The t-shirt that we are wearing is from Afra Media Consult, and also Design Pharmacy. So we say a big thank you to all of us here too for being here. To my able volunteers who came all the way with me from Accra. I'll say a big thank you to you. God bless all of us and grant our heart desires. Thank you. Let's enjoy it.
Thank you so much, Madam President. And thank you all too for sticking with me through the side dishes. Now we're on the main course. We are about to have a presentation on this year's awareness theme, thyroid diseases are non-communicable diseases. We are blessed to have the consultant surgeon and the clinical director of Eastern Regional Hospital, Dr. Foster Amponsa Mary. Please.
Good morning.
Good morning.
An advice to the young ones, don't go to the market looking for thyroid because they are going to carry you for every presentation. Yeah. So, I would like to welcome all of you to this presentation with permission from the founder, the management of the hospital, the chairman, permission from the chairman first, huh? Then it goes to the founder, the management of the hospital, all senior colleagues present and everyone present. We want to go straight to this talk, which is a very thorny issue going on. And it talks about thyroid being considered as non-communicable diseases. And it's a call that we will want all of us to join for the betterment of all of us. I will say that I have nothing to disclose as it goes. WHO in her license classified diseases being it part either communicable or non-communicable. And as part of the non-communicable diseases, we know that most of the chronic diseases that tend to last for a longer period are considered as non-communicable diseases, especially if there are some genetic influence, physiological or environmental influence, as well as behavioral factors that affect it. We all know that more often than not, diabetes, cancers, heart diseases, strokes are considered as non-communicable disease. And now more than ever, the trend has been on to fight non-communicable diseases since they are part of the entities that are killing us most. We tend to look at the causes being from either inactivity, alcohol abuse, tobacco abuse, or our diet that we eat. And these are things that are killing us. So, as we all know, most of the people that die are dying from non-communicable disease. And about 74% of the global death is from non-communicable diseases. The sad part is that those who do not have are the ones who die most. And 77% of the deaths are coming from our region. Therefore, it is a call for us all to wake up. How can we combat non-communicable diseases? It's just by one, detecting it early, screening, creating awareness as we are doing now, treating them as and when they arise, and more or less just do the palliative management. But above all, try to prevent them. That is the most important thing. Now, sometime back in 2008, the European Community, or the European Association, Thyroid Association, declared the 25th of May as the World Thyroid Day, because there's a call for us to be aware of thyroid diseases. And 2 years after, all sister associations had accepted it. We would say that we accepted it about 6 years ago, but we are part of the sister associations. Now, the question is, are thyroid diseases non-communicable diseases? And that is what we want you to think about as we go on in the talk. And if you agree, then you join us in the battle to make it part of the non-communicable diseases. When we talk about thyroid diseases, what are we talking about? We're just simply talking about diseases that might even be as a result of the function of the thyroid, it being the size that modifies or the structure of the thyroid that modifies. In that sense, it could be that the function of the thyroid gland is high. That is when we talk about hyperthyroidism. Or the function of the thyroid gland is low. That is when we talk about hypothyroidism. Or even when the thyroid function is of its normal, but then there is some disease in it, being it in the structure, the function, or the texture. There are some diseases like the nodular thyroid, autoimmune diseases that affect the thyroid gland, or cancers that we see to be affecting the thyroid gland. Now, the truth of the matter is that most people, more than 200 million people are affected by thyroid. And it's not only in areas that have deficiency in iodine, but in areas that might even have. And you can see that about 0.2% to 1.3% of these diseases might, from places where you have sufficient iodine, might be having hyperthyroidism or a palpable lump. Cleglamte and co. in Kolebu, somewhere in 2013, published an article looking at the prevalence of thyroid diseases in Ghana. And what they noticed is that the annual incidence is about 185 cases of thyroid in Ghana, mainly data coming from Kolebu. And the common malignancies they found was papillary carcinoma, even though we are not, we are part of the people who are considered as iron deficiency, and you should find follicular cancers more often. Here in our hospital, looking at our data from 2021 up to 2023, we had operated about 237 cases, most of them being female, quite a few of them being male. Now, when we talk about goiter, we're simply talking about an enlargement of the thyroid gland. And you've seen some of these things go to theater. At the end of the day, this is what we come out with, that the lump is taken out. When does the thyroid begin to develop? Right from the third week that mommy and daddy met. It begins to develop. And it develops at the base of the tongue. Then it grows. By the time the child is born, it's way down on the neck. But actually, around the 8th week, it begins to descend. So you see that it's way down around the neck where we usually find it. What happens that sometimes you could have some remnants in the base of the tongue. So you could have an ectopic thyroid, or you could have what we call a thyroglossal cyst. That is where the duct, the way where it passed, never closed, and therefore something persisted. Then, what is interesting for all thyroid surgeons, and way back, Koche noticed it, that when you are going to operate a thyroid, you have to be careful about the anatomy. Okay, the recurrent laryngeal nerve passing behind it, or just close to the vessels, and if you damage it, then the person might not be able to talk well, or the person might not be able to breathe at all. Therefore, you might have to do a tracheostomy. These are some of the challenges that come with the thyroid. But I'm not here to scare you. I'm here to tell you that the thyroid is a very good gland and participates in all basic metabolism. Your production of energy depends a lot on the thyroid. The simple thing being that if you want to produce any energy, you need iodine. Your thyroid has to come into play. It helps us become active. It helps us become dull, that is if it's not working well. It helps us sleep well. It keeps us awake if it's not functioning well. The thyroid gland increases our heat production, our oxygen concentration, and all these things, the thyroid gland participates in them. Hello?
Hi.
Are we here?
Yes, we are.
All what we're telling you is that thyroid is a very important gland in the human being. And this was noticed way long ago, way long ago, in the BCs. somewhere 2700 BC. Now, it was noticed that the thyroid gland does a lot of work. What are some of the pathologies? Like I said initially, the thyroid gland can function below its function, that is hypothyroidism, or high above, and that is the hyperthyroidism. Some of these things being the thyrotoxicosis. Some people talk about the Graves' disease, okay, or the toxic adenoma. All right, these, or sometimes it can become malignant, the follicular cancers. The good thing about the thyroid is its cancer, if it is follicular or papillary, doesn't kill you early. Sometimes 20 years, people will not notice. And you see how good thyroid is. Other cancers will just kill you early. That is why we have to love the thyroid. So the clinical presentation, the two most common presentations is that it might function below, that is hypothyroidism. And when somebody has hypothyroidism, you might notice that the person becomes easily fatigued. He easily gets tired, begins to gain weight, gets depressed easily, is lethargic, gets dry skin, does not tolerate cold at all, cannot live in a grocery. Okay? Then there are some changes in the menses. There could be some cramps in the muscles. All right? Sometimes we cause it. Now, in hyperthyroidism, this is that person that you see that is eating everything. Eats a lot but never gets fat. Eats a lot and still losing weight. Okay? It's anxious. In fact, people tell them as being crazy sometimes. They are anxious and nobody understands. They easily pick quarrels. Anything at all becomes a quarrel for them. Okay? They sometimes have diarrhea. It's eating and it's just it's mouth to toilet. Eat and just go. Eat and just go. They have palpitation, muscle weakness. They tolerate heat a lot. Sorry, they do not tolerate heat because they feel there's excessive energy production. There's excessive heat. So he will live well outside, laboratory. Okay, doesn't stay in well here. And these are some. Or sometimes it's just an enlargement of the gland, and you can see that some people will feel some pressure in their throat. They swallow and they think that they are choking, and the gland might choke them. These are some of the manifestations of the thyroid gland. Now, how do we diagnose the thyroid issues? Usually, it's by clinical examination. Somebody comes to complain about some of these things. Then you want to examine them. You palpate the neck. You might feel that there's an increase. Or you check the pulse and the pulse is fast. Or you feel the leg and you see that it feels rough in front of the leg. Okay? These are some of the things. Then we will want to go and investigate, do some labs. We check the thyroid function test, that is the TSH, or the T3, T4. These are key ones that will tell us once they are up or they are low, then we know that there is something going on. We'll proceed to do a neck ultrasound. Sometimes we do a chest x-ray to see if there is prolongation to the chest. A neck ultrasound to tell us if the gland is enlarged, that is one, or if it is cystic, that is if it has fluid in it, or if it's just a solid, or if there are multiple lumps. These are some of the things that, if it is cystic, we might want to stick a needle in and send some for histopathology. We do some images, like the x-rays or CT scan sometimes, if it's cancerous or whatever it is. Then we will proceed to counsel you for treatment. Sometimes it's just medication. We give some medications they take. If you are too high, we always want to bring you normal. That is, if it's hyperthyroidism, we want to bring you to L-thyroid. Okay? Or if it's hypo, we want to bring you to L-thyroid. The three reasons, more often than not, that will push any surgeon to operate a goiter or a thyroid issue is one, if it is functioning above its level, or if there's a suspicion that is cancerous, or if it is compressing, that is, if it's choking the person. Sometimes it grows to compress the windpipe or the airway, or what we call the trachea. It compresses it. In that case, then we are pushed to operate, or in more often than not, statically, people feel that the neck is too big, and let me just take it. And you give them a nice scar, and they are fine like this, and they laugh fine. There are times that it becomes malignant. Even sometimes it's not malignant, but we might have to use some chemoradiotherapy to burn it down. Then, in that case, the person becomes hypothyroid. That is in those cases of thyroiditis, or Hashimoto or some of those, the person might go high, then come down. So you want to treat them. This is where my key question is. Do you think that the treatment for thyroid is just a one-stop thing? No. If you do agree that this is not a one-stop thing, it's a lifelong treatment, because once we start, the person, one, has to modify your activities. Two, if we operate you and you become hypothyroid, that is a iatrogenical hypothyroidism, because we took out the gland and you became hypothyroid, we have to put you on thyroid supplement, which is better than if the thyroid is even functioning more than this, and we have to suppress it. In that case, it means that these treatments are lifelong. Okay? If that is the case, then you can see some similarities between what the WHO has defined as what non-communicable disease and what we're talking about, this thyroid disease. That once